Well, good morning, everyone, and welcome to Taste for the Cure. We have been doing this program for over 20 years. This is a beloved tradition that we've had in our community, and I am so excited this year to do our very first virtual Taste for the Cure. We are not daunted by COVID. We take it seriously and we protect ourselves from it, but it doesn't stop us from doing the things that are important, like this very important program where we can bring to you the latest advances in science and health and nutrition to improve your survivorship experience and to help educate ourselves, the community, and to think about how we want the future to be better. So today we have a really exciting program for you. And I hope some of you have your exercise clothes on, because after we do our first panel, which will be very exciting, we are going to have a quick set of lightning talks to give you a taste of all the things that are going, some of the things that are going on at the Breast Care Center to improve the future of treatment and prevention and screening. But then we're going to have a Zumba class to get everyone starting in the right foot and getting some exercise. And then we have a very special treat for you around science. And we're going to talk about a new and emerging tool to help tell us where the tumors are. It's called Circulating Tumor DNA. And our very own Laura Vanfier will be doing that presentation for you. So this is 2 hours today, but to break it up into chunks, we are going to repeat, or we're not going to repeat it, we're going to have a different version of this next week, where we're going to be talking about rethinking the standard, how new classification of tumors can improve treatment. That's going to be our panel next week. And we'll, of course, have our famous cooking class. Allie Mountford and I will be in the kitchen showing you how you can use leftovers, healthy food, and we're going to do it all on Zoom. We're not exactly sure how, but if you want to see it, come in next week from 9 to 11, and we'll do it then. Okay, so to highlight our first panel, and our first panel really is going to focus on, how, I'm going to focus a little bit on screening and guidelines, and the guidelines around how all of our assessments of risk apply to the population, where they came from, and why it's so important to have diversity in the populations when we actually do our research. This is a landmark study testing a personalized approach to screening compared to annual screening. And what we are hoping to do is demonstrate that there's a better way forward with screening. We know that all breast cancers aren't the same, and we know that everyone's risk isn't the same. We don't treat women with breast cancer the same. We do it based on what kind of tumor they have. But in the population, we don't know who's at risk for what kind of cancer. That's something we're trying to change, because we think that learning how to screen and give prevention recommendations should depend on your own risk. And that's really what the Wisdom study is all about. It's women informed to screen depending on measures of risk. If you've had breast cancer, you're not eligible. But everyone in this audience knows people who have not had breast cancer. So please spread the word and tell people to go to wisdomstudy.org and sign up. It's that easy. But we're asking women to spend 5 years of the next 30 years they might ever spend screening, and spend it with us and help us get better answers. So I want to turn to my esteemed panel. We're very excited with the panel that we have today, because what's exciting is that we can have people from anywhere virtually. So that's really very exciting. So on our panel, we really want to talk about why is it so important to make sure that we really represent everyone in the population, and I think that the first thing to think about is, in screening guidelines, those screening guidelines about risk, where do they come from? And are we really doing as good a job as we can to include everyone at risk? One of the questions we want to know is, how do we know about our own genetic makeup? Our families have maybe intermingled in many ways. How do we know what the right risk factors or based on our genetics should be? How do we rethink that? So I wanted to start with my very close friend and colleague, Dr. Fumi Alapade from the University of Chicago. As I go to each panelist, and again, I want to say that we are very excited. Let me just stop for a second and say that on our panel, we have Dr. Fumi Alapade from Chicago, Dr. Jennifer James from UCSF, Kim Rhodes from UCSF, Alad Ziv from UCSF, and Celia Kaplan. And we're going to talk about each of these ideas in turn. So Dr. Alapade, the first thing I wanted to ask you is, where do our treatment guidelines come from? And are they really good enough for African-American women? Should they feel comfortable that the guidelines about risk and risk assessment really apply to them?
Yeah, so thank you, Laura, for inviting me to this panel. And it's really wonderful to be able to do this virtually. As you know, not every person has the same risk. And I think we've talked about that for decades, ever since you and I met. And we've been trying really hard to make sure we can do personalized screening based on measures of risk. And so in general, there's an assumption that all women from the minute that they're born have a risk for breast cancer, because the most important risk factor is being a woman. But then that's where it ends. And it doesn't mean that one day you'll wake up, you're 50 and suddenly you should get a mammogram, or you're 40 and you should get a mammogram, because not every woman has the same risk. And that's why I have been pushing for a very long time to think, first of all, about the population that you are screening. And that's why we've talked about population differences in the type of breast cancer that you get. Yes, if your risk for a slow-growing indolent breast cancer that you might die of other causes before it kills you, then of course, you can wait and you can choose whether to screen or not to screen. But if you're an African-American woman at risk of dying from breast cancer before you're 40, or between the ages of 40 and 50, what should you do if you have a risk of aggressive ER-negative breast cancer? And that's why I was really excited to join the Wisdom study and really encourage other women of color. And the same thing can be said for women who are non-European ancestry, who cannot trace their ancestry to Eastern Europe or Western Europe. What is your risk for breast cancer? If you come from Brazil, if you come from Panama, if you come from Jamaica. And so because the US is an immigrant nation, what about that Asian woman who came in from Beijing and now lives in America? So that's why I think we need to push the envelope and we need to begin to define risk based on each person. And yes, the guidelines are there. And I don't want to throw the guidelines out because they're supposed to help us help women make choices. And we can move beyond guidelines by doing research, asking questions. So yes, the guidelines are there now. We're not there to tell every woman to stop screening. And so that's why we're doing the Wisdom study and we're asking women to consider joining Wisdom study when they decide to get that mammogram.
That's
I-
right, Fumi. And of course, you should know you've been studying studying genetics since I've known you for at least 25 years. And Dr. Olapati, by the way, is an oncologist and an expert in global health at the University of Chicago. And you know, the one of the reasons why the guidelines are also so confusing is there are so many of them. There are at least 7 in this country, and they don't agree with each other, and none of them agree with most of the guidelines that are out in European countries. So we think it's high time to let the data tell us what the guidelines should show, and we can see if a new tailored way of screening towards your risk and integrating prevention would be just as safe, more preferred, you know, lead to less false positives, and improve our uptake of prevention and be a better healthcare value. So that's the big experiment we're embarked upon, and we can't do it by ourselves. We need, you know, we want to get 100,000 women in the study. We are excited to say that we have 30,000 women enrolled so far. That's very exciting, but we'd like to double that number this year. So tell everyone you know. So speaking of the way Dr. Olapati answered her last question, saying like, what is our risk? You know, I want to ask Elad Ziv, who is our scientific expert on this, what is it that we can learn about our genome, or while looking at the genetic makeup? Oh, and Dr. Olapati, please keep your camera on. So all the panelists, as you come on, just keep your camera on and continue on. So I'd like to know, you know, what is it? Can you tell everyone listening what it is that we can learn about our risk just by looking at the genes?
Sure. So in terms of genetic risk of breast cancer, first, there's a lot we don't know. But of the things that we do know, we know that there are high penetrance susceptibility genes. For example, many women have probably heard of BRCA1 and BRCA2. And these are genes where if you inherit a mutation, basically a misspelling, if you will, of how the gene is supposed to work, if you inherit that, your risk is very high of getting breast cancer. The mutations in those genes are quite rare, so it's very unusual for a woman to have one, but those women are at high risk. The mutations in those genes are vary by population. In other words, different populations have different misspellings, but regardless of which misspelling you have, if you inherit a variant that causes risk, the risk is we estimate it's about 60 to 80% lifetime risk of breast cancer, and lower risk of ovarian cancer, but also the much higher risk of ovarian cancer than the general population. Now, there are other genes that have a slightly decreased risk from that, but also quite high. So for example, a gene called PALB2 and other genes like CHEK2, if women inherit those mutations, they have a very high risk. But then there are a whole other class of risk of genetic variants that are common. So very many women have them, but they really very modestly affect your risk, each one of them. But we know now that there are over 200 of them, and there are probably more. We're learning more all the time. Really, for those genetic variations, it's not really having one or two of them. It's really the combination of variants that you have, that you inherit, really determine your risk. And everyone is, I would say, sort of on a bell-shaped distribution of risk based on those variants. And some women end up with a combination that is unusually high, and their risk can get quite high. Whereas many women, most women are in the middle. And there are some women that actually have lower than average risk based on the combinations that they inherit. So that's kind of the state of the art of what we know today. And, I think the interesting and I think exciting thing about the Wisdom trial is that we're actually combining both of those pieces of knowledge into our risk assessment when women come into the trial, and at least women who are going into the precision medicine arm. And so we figure out whether they have a BRCA1 or a BRCA2 or PALB2 or other genetic mutations that increase their risk to very high. And for women who don't have that, those mutations, everybody else in the precision medicine arm at least gets, we measure a combination of over 200 variants and sort of determine where you are on that kind of bell-shaped distribution of risk. And we are trying to tailor the recommendations for screening based on that assessment. And we're not just using genetics because it's not really about all about genetics. There's a combination of many other risk factors. So we're using also mammographic density. Obviously, we're taking age into account as well to get an estimate of each woman's 5-year risk. And based on that combined estimate, we're assessing risk and putting women into different categories for screening.
And Dr. Ziv is not only interested in the science of pushing the science of this, he actually is a primary care physician at UCSF, so gives guidance to women about how often they should screen. So he too is looking for better guidance on this. And we're going to talk during the question and answer. I'm going to talk about the opportunity to, how we can apply this to people that we're treating. So risk probably should, your underlying risk should probably influence how we do future surveillance. That's Wisdom for Cancer coming soon, once we learn something from the trial. So it's kind of cool. We're trying to take what we've learned about invasive cancer to the screening and prevention world. And now we're going to take the knowledge from screening and prevention and help it see how it improves our the way we manage people after they've in their survivorship years. So I'm going to turn now to Celia Kaplan, who has been someone who has been studying the different impacts on Latino women and has been trying to think about ways in which we make sure to include Latino women in trials, and we think about the diversity of our population. Celia, why should Latino women care about this study, or why should anyone even?
Am I online?
Yeah, perfect.
Hi, good morning, everybody. This is a very important question, and I will give you the short answer. If we do not have enough women of a certain group, we will never know whether a certain intervention like Wisdom study works or not. That's why we all want not only Latinas, but women from different groups, African American, Asian Americans, everybody to participate so our conclusions can apply to everybody. Latinas in particular are a very important group. We are 40% of California. We are 17% of the entire country. Unfortunately, Latinas do not screen at the same rate than other groups. They have lower screening rates. And it has been investigated a lot, and the reasons are multiple. They are structural, they are geographical, where do you live? They are language, they are issues that are cultural. And one of the things that I love about Wisdom, and that's why I participate as an investigator with enthusiasm, is because not only we have the basic science, we have the clinical aspects of it, but we also have the behavioral aspects that we can investigate. Will Latina women accept all the elements of a personalized screening? And if we can find out what are the elements that promote screening, what are the elements that deter them from screening, we will be able to intervene early on, not years down the line where inequities are present, but just in the investigative phase in order to address those barriers and help this group achieve screening rates similar to other groups.
So that's great. Celia, I want to turn now to Dr. Kim Rhodes. Kim has actually just joined joined UCSF in the last few years, and actually she did her surgery training here, but now she's really looking at populations, and she's now part of the Cancer Center and on the board of directors. So, and thinking about community outreach. So Kim, I'd really like you to maybe discuss why it is that we have just not been as successful in reaching out to all populations. Why is it, that we have not been as successful as we should be in including all women or all people, all kinds of people? I mean, initially in trials, we mostly did trials on men. It's very hard to do a breast cancer trial just for men, of course. So that isn't our problem in breast cancer, but a lot of our trials were just not that successful, and the diversity of our population really is not reflected in who joins trials. Why is that? And why is it so important to change it?
So thanks, Laura, for having me on for this Taste for the Cure. I just want to mention that I am the Associate Director for Community Engagement for the Cancer Center, and in that role, I facilitate the interactions of our Community Advisory Board with many of our investigators across the center. And this question kind of raises for me, the question of why we have not been as successful as we would like to be in terms of representation in the wisdom study. I think about something that our Community Advisory Board Director, Arnold Perkins, says all the time, which is, you can't teach what you don't know, and you can't lead where you won't go. And it raises two really important points. The first is about teaching what you know. And what it means here, I think, in this case, is that you have to have representation on your team. And whether that representation is in the form of faculty members and other investigators, or in your community advisors, there has to be some input that comes from direct experience of being part of a particular community that is diverse from, say, a collection of folks who are of European ancestry. And it's not just about race. I mean, it also reflects on sexual and gender minorities, physical ability, other ways in which people can be sort of left out or marginalized and not thought of as part of the norm or the mainstream. So it's important to have those kinds of inputs, because folks who are having the direct experience can tell you where you need to be in terms of your focus on engagement with different populations. Everybody's not sort of clustering in the same place. I think one of the first strategies for recruitment was reaching into the UC system and trying to engage the staff. And I always think to myself, I wonder, did that engagement reach the women of color who are not necessarily physicians or in higher levels of delivering care, but maybe changing the sheets in the bed, in the rooms in the hospital, or working in the cafeteria? And if that engagement didn't reach all across the elements of these different healthcare systems, knowing that the workforce is segregated within the healthcare systems, then you're only going to reach a certain population of folks. The second piece I sort of alluded to, that you can't lead where you won't go. So part of a strategy that I think would be beneficial to wisdom is to actually be engaging in the community where community gathers. So showing up not just at health fairs, but also at social gatherings or gatherings that are facilitated by organizations. And obviously in the time of COVID, this is quite challenging, but as we all transition to these online platforms, there are these opportunities. I know that our current leadership board is quite diverse and has recommended things like engaging with the African American sororities, for example. So what you're doing by sort of being in these places is finding the key influencers, number one, or the trusted messengers who can actually deliver the message about the importance of wisdom and the importance of representation in a study like this probably better than we can as institutionalists. So again, I just want to reemphasize, you can't teach what you don't know, and you can't lead where you won't go. And I think if you stick by those two principles, you'll start to form different kinds of teams, and you'll start to engage with different populations because you'll know where they are.
Thanks, Kim. Those are wise words, and we are working hard to follow them. Jen James has a special role on our wisdom study. She actually represents our ethics group, and we actually have an embedded ethics study in our trial, just kind of looking at the way people react to how we invite them to screen, what the messages are. So kind of watching us in a fair and unbalanced way to try and help us do a better job of our messages, trying to find out where it is that we might have missed the mark and how to make changes. And they play a really important role. And maybe, Jen, you might want to reflect a little bit about, you know, the reasons why people either do or don't want to participate in research, and sort of where they have fears, and what is it that we can all learn about that, and how is it that we have to make sure the ethics of our trials and our the way we go forward is unassailable, because research is the bedrock of the future. If we keep doing the same thing over and over again, we will never have a different result, right? Everybody understands that. And I think everyone on this panel and everyone in the audience could say, we certainly can do better. You know, we are screening the same way we did 40 years ago when, you know, we didn't even know there was an estrogen receptor. So if we want change, we have to do research. Research actually is really just asking the question of how are we doing and can we do better? There's nothing fancy about it. That's not a guinea pig. That's nothing else. This is a very different concept from what maybe people had in mind before. But this is really about how do we just get better? How do we take advantage of everything we've learned and make it better? So Jen, perhaps you could comment a little bit about how we should message about what is a study or what is research, and, you know, why is it confusing to people, and how do we do better?
Yeah, no, that's a great question. Thanks, Laura. And so yeah, I'm a sociologist, which is a little different than many of the MDs on the panel. And I'm a qualitative researcher, which means I have the privilege in my work of talking to people and really learning about experiences of health and illness from the experts, from the people who've lived it, the people with cancer. And as Laura mentioned, with the wisdom study, you know, we are talking to participants, we're sort of watching the trial unfold, we're doing a study of the study, which is a really cool thing. But outside of wisdom, a lot of my work is fairly different. I'm doing work that's community engaged, where I spend a lot of time in the community talking to people about research. So I spend a lot of time talking to non-academics about doing research. So I feel like I have a good lens on this. And you know, first, I think one thing that's important is historically, a lot of research has been pretty extractive. We talk about research as being vultures, right? We sort of come in, take what we need from people and leave. And I think people want to participate in research that has value to them, sort of both personally, is there compensation for my time? Is there information about my health that might be valuable to me? But also for their family and their community more broadly. What's the plan to return this knowledge to the community? To make sure that, you know, the people who generated the knowledge can benefit from it later. So I think making that really clear is something that's important. Second is something, I think this relates to the topic of this panel really well. There's a quote I've seen on a t-shirt that a UCSF colleague, Monica McLemore, has worn. I don't know who actually said this quote, but I love it. And it says, there's nothing wrong with Black women that solving racism can't fix. And this resonates with me for a couple of reasons. So first, I think it's important for us to recognize that, you know, race wasn't created by science. It wasn't created by whatever higher power or biological process you believe sort of created humans. Like race was created by racism. So we have to make sure we're not framing the need for diversity in research by saying that there's certain groups of people that are inherently different than others. That sort of just reifies and recreates these differences and a racism, really, that people are inherently different. What it is that the need for diversity is that it's important to include a diverse range of experiences, because we have so many different experiences in our country that have led to many of the health outcomes that have happened, and that has happened based in racism. So we see this along racial groups, but it's because of things like housing policies and where pollution is and what our diets have looked like and who's been able to marry whom. Like all of that has led to these health outcomes. But I think reminding us that this is based in our sort of current and historical failings as a society. It's not that we need to elucidate or find the differences between these sort of socially constructed groups, but we need to understand how our policies that go back, thousands of years, how our society's been organized have influenced our health. And I think for many people of color, and this is something I've heard a lot from Black women, it's frustrating to sort of always hear from science and medicine that we're failing. We're more at risk for disease, we're more likely to die from disease, we're making less money. There's so much that it seems focused on only talking about disparities. And what I hear is we know there's disparities, we live them every day. And I think we need to reframe that. We need to be clear when we're recruiting people for participants, like, it's not just that Black women, that Native American women are more likely to die from breast cancer. It's that we've created these conditions that have allowed for this. And then as medicine and as research, we haven't yet found the solution. We need to do that. This is on us as researchers, not on you as a participant. We need to find that solution for you. So in describing research, telling people how we're going to change the systems that have created these disparities and how we're going to give you tools to improve your health. And then finally, I wanted to just touch on trust. I think this is something that comes up a lot when we talk about research. And one misconception I see is I think we often think about it only in terms of historical injustices. So we think about these huge ethical failings like the Tuskegee syphilis trial or things like Henrietta Lacks. And I think sometimes we focus too much on that in a way that lets us as researchers off the hook. And I think many people don't trust medicine or don't trust research because of experiences they've had in their own lives. Like I know so many people, friends who are people of color, who talk about when I go to the doctor, I wear my UCSF shirt or my Harvard shirt to sort of indicate, I've been to a good school, or I casually drop into the conversation like, oh, I'm a chemist, so people will see me differently. And that's a big problem. Not everyone has those markers they can drop, and people shouldn't feel like their healthcare is going to be different based on that. And I also see as a researcher, when I go out in the community and I say, oh, I'm from UCSF, sometimes people make this face like, oh, who are you? And, UCSF hasn't had one of these landmark ethical failings. We're not sort of known as being horrible researchers the way some historical institutions have been, but people still feel like, I haven't had a good experience, or I've talked to so many people and I haven't gotten anything back. And so I think we need to acknowledge that, like, we have to respond to the failings of some of our colleagues who've done research that hasn't been truly community engaged. So I really think research should start with asking the community, coming in and saying, I'm a researcher, this is what I do, I study breast cancer, this is how I want to make things better, what do you need? How can we work together to improve your health? What do you want to know? So I think the messaging has to start with finding out from the people what they want the research to be, and then shaping research to look like that.
Oh, Jen, that was just so helpful. I think that that's really important. And I think that brings us to our first, one of the first points that we can make is that, out of the wisdom study, a lot can be learned. For one, Dr. Olpade, you like to talk about precision prevention. Is that possible if you don't really have precision risk assessment?
Yeah, so thank you, Laura, for coming back to me. And I really enjoyed Jennifer's comment. But I also have been really pushing that race is actually not a social construct. It's only a social construct in America. There are Black people all over the world. They are Black and they are proud and they have to raise their heads up. And so in this era of racism that is really, transacting with the pandemic, you can see when you deny science, when you don't test, and when you are poor, it doesn't matter where you live, rural America, urban America, you're gonna die from corona, right? That is what we know about science, testing, and really making sure we understand what exactly is causing disease. So my work has taken me all over the world. And if you go all over the world, if you go to India, you're gonna know that sometimes young women get breast cancer and there may be a genetic basis for it, right? There are more Black people in India than in America, but they don't call themselves Black because American history has contaminated what it means to be Black. So I always have to push back and correct Black Lives Matter all over the world. And sometimes colonialism, sometimes the oppression of people in the Amazon, indigenous people, will make people who are not lily white, as I call it, like my good friend Laura, because she's my evil twin, and we tease each other about it. But there's really a scientific construct and a scientific basis for thinking about racial groups. And so when we start talking about genetics and genetic testing, it is really the case that we need to do more research on Black people across the diaspora, period, because people live in different environments, and the environment and the social determinants actually influence your genes. So that's why some people will get breast cancer. And I know that Laura is going to talk about mama print and about gene expression profiling. If you do gene expression profiling, it is because of your genes that are driving your cancer in a specific manner. Now, those genes are being acted upon by social determinants. So that's why for wisdom, we're talking about, let us continue to recalibrate what is genetic and how does the genetics actually interact with the environment. So our social scientists need to talk to us, and I'm glad that you're part of and you're witnessing this, because in Chicago, I have constantly talked to my community. And now when I go, you know what they do? They sign up, right? Because they want to be part of the solution. From my time at Cook County Hospital, from my time now on the south side of Chicago, every patient who walks into my clinic is diverse. And when you communicate with them, when you tell them why it is important for us to do genetics research, that we're going to learn about it, then they participate. And what has been a failure of our biomedical research enterprise, because we have such racism, is that people have been segregated. They've been segregated in where they live. They've been segregated in how they live. I'm a Nigerian, and Laura knows that my way of life is very different, right? Because of the way that I have been acculturated. So culture matters, right? What you eat matters. Now we're talking about microbiome, and that's why it's really important. We're not going to get it right immediately, but wisdom is allowing us to revise, revamp, expand, and then bring in an inclusive. So what I like to use is that we need to be inclusive. We need to learn from our patients. We need to learn from them where they live. So wisdom, I'm not doing it at the University of Chicago. I'm taking it to Ingalls Memorial Hospital, which is where Laura was born, right?
That's right.
And we know that, on the south side of Chicago, there have been a lot of people who left to go to greener pastures. Well, there are people who still live on the south side of Chicago. And our job is to go there and make sure that we meet them where they live and that we make services available to them. So I really think that wisdom can bring us all together. Elad, for example, has found that, in fact, Latina women may have a lower risk for breast cancer. How do we factor that into risk stratification? So I think we have a lot to learn, and that by learning, we will then know precision prevention. Right. Because what I was trained in medical school is prevention is better than cure. And that's why as a medical oncologist, I'm going out there and I'm saying, let's prevent cancer. We can prevent a lot of cancers once we know what you are at risk for.
That's right. But the problem is, unless we start to understand who's at risk for what kind of cancer, some of our current prevention tools, which are great if you're getting a hormone positive breast cancer, may not be the trick if you're at risk for a hormone negative treatment and cancer. And so we need to also generate new ideas, and that's what we're about. What I think is exciting also is that if you know better what your underlying genetics are. If you have a predisposition to getting another cancer, that should change the way you do surveillance, even if you've had cancer. So what's going to come out of this study is going to be super important for everyone, not just people who haven't had cancer, but it will help us in our thoughts about prevention. Laura Vanfier has graciously agreed to read off some of the questions that are in the panel or that are being asked by people in the chat. So those of you who are out there who have specific questions, please just type your questions, click on the chat, type a question, and Laura Vanfier will be helping to bring some of those questions in. So Laura, do you want to tell us a couple of the questions that have come in?
Yes, I'll do so. The questions are in the Q&A button. The first questions were about how can I join the study, and if I live in Texas, can I join the study? I think that's a question you can.
Okay, that's an easy one. So anyone, anywhere in the United States can join the Wisdom Study. If you go on your phone or on your computer to wisdomstudy.org, you will see the information. It's as easy as putting your information in and signing up. So far 30,000 women have enrolled. We actually have 40,000 women have gone to the website to learn more, and 30,000 have actually joined Wisdom. As Maya Angelou says, the only way, to do better is to know better. So, if we all participate, we can all make it better for ourselves. If you've got cancer, to learn how to screen and monitor better, but I think also this is going to push the field of prevention forward, which could actually influence treatment. So, but more importantly, it will give us information how we can advise people to screen. So Laura, another question.
Another question is, can everybody participate, and specifically, is there an age limit, and can only women participate, or is it open to all genders?
This is for women, and it's actually for biologic women. So if you're trans, you are still eligible. Cancer is just not common enough in men to make it worthwhile to screen. Once we understand more about about risk, there may be a way in which we can, we can extend this knowledge. We have picked 40 to 74 because that's primarily the age at which we screen. But once we learn who's really at risk, this might be our risk assessment is something that can be done at any age, and probably should be done at age 30, so that we can capture those people who are truly at risk. One of the things that really struck me the first time I went to Nigeria with Fumi was how many young women had really in their 30s, late 20s, had very virulent disease, bad disease. And I thought, wow, this is, our treatment should be different. And in fact, there's a lot we can learn, right? That it's about when we see this, we now know, as we said, we don't treat every cancer the same. So this is important. A lot, I might say that, the construct in genetics isn't really about race. It's about underlying risk factors, right? And that maybe that's the great equalizer. Is there an opportunity to rethink risk in that construct? Alad?
Yeah, I think that it's a work in progress. I think we're still learning a lot about about risk. And unfortunately, we actually know less about risk in women of non-European ancestry. So while actually many people on this panel, including Fumi and myself, are working in populations of non-European ancestry to try and understand risk better, we've been working with much smaller sample sizes than the European ancestry samples that have been studying risk. I would say that I think it's complex in terms of how to think about genetics in this context. I think that ancestry is probably a more useful idea in the field of genetics, in the sense of where your biological great ancestors from tens of thousands of years ago come from. may have more of an influence than your self-described race in terms of what genetic variants you have. But the truth is that there are genetic risk variants in all populations, regardless of ancestry and regardless of race. And we just need to kind of understand them better, both which variants affect risk in each population, number one, and number two, what are the other factors that modify the risk, the social factors that may influence, even regardless of your genetics, may modify the risk of breast cancer.
And Laura, if I may just
put some emphasis on what Elad is saying, because I think the problem that we'll run into if we keep ourselves in the boxes of race, you know, I think about my young daughter who, being the child of an interracial marriage, being half white, you know, there is not really going to be a box that fits her profile, but looking at whatever we understand about genetic risk and not seeing her as a color, but rather seeing a genetic profile, I think over time is actually going to be more helpful. Even though we are in a time of tremendous racism, we also are in a time of tremendous miscegenation. And so these boxes are actually going to be a little bit disrupted. So I think that,
good, yeah.
About the, like, thinking about it purely biological and disconnecting it from someone's color, I think is going to be much more useful in terms of getting us to equity and screening, because it's personalized to the person, not to their color.
Right. And I think that's an important point, because, you know, if you've got a mutation, it doesn't matter whether you're Black or white or Latina or Brazilian or, you know, Native Alaskan or Maori, it shouldn't matter. You still have risk and risk associated for breast cancer. And so that's what we really want to get to, is sort of a precision notion of what is risk and how to adopt treatment to make it better. And the thing about it is everyone benefits. Everyone benefits. If we understand, so maybe in Nigeria, 3/4 of people have hormone negative cancer. And maybe in the United States, 20% of people have these hormone negative cancers. But when we figure out how to treat them better, you know, if you were someone, I just did a consult for someone who is 84 and has a really nasty triple negative breast cancer. That's very unusual. She's white, you know, she's much older. These are, you don't expect people to get them, but people can get any kind of cancer at any kind of age. And the more we know about these different cancers and how to treat them, the better off everybody is, because at the end of the day, anybody can get any kind of cancer, and you have to know that. And the strategies for the population will be better when we figure that out. So I think that's a critically important point. And I forget, maybe Celia, you said it, but this is a way this study can help us come together to really, you know, get out of our boxes and really think about what's the underlying risk. And, you know, and these tools then can work for everyone as long as we have broad representation in the public. I think that's true.
So one of the things that came
I have two types of questions for you, maybe to guide you a little bit. And I think one type is, so I'm participating in a study, but what do I do in the meantime? Do I get any advice? In particular, if I'm not of European descent, how good is that? What can I do? The other set of questions is, okay, why can't somebody who is 30 years old from a breast cancer risk family, or if I had DCIS, or if I'm in survivorship, not participate? Two types of questions.
Okay. So let's go back to
one after that.
Okay, let's go back to the first question. So I'm in the study. What can I do, or what can I know? So unfortunately, this study isn't something where we have information and we know immediately how to make it better. We have to have some time for it to, we're marinating the sauce, so to speak, where we're learning. But within the study, everybody has the chance, you know, if you are, we have a breast health decisions module. So if you're in the study and you happen to be in the personalized arm, you can go in and look at your personalized risk and see what increases or reduces your risk. That's something, those are guidelines that we have, and we have the general guidelines. If you're in the annual arm for now, and that's what people are doing anyway, often, or sometimes, that we're just going along with those arms, but we are really trying hard to do an outreach to the people at the highest risk that we see as the highest risk. Any other comments just on that before we get into why we made it 40 to 70? Fumi, you want to?
May I say something?
Yeah.
I think the challenge that we all face, and I really appreciate, Kim, your comment about mixed race individuals. And Elad and I and Laura, we spent every other Monday thinking about how we should deal with people and their self-identity, right? Because how you identify also determines how you live your life. And so these are some of the really pressing questions that I hope wisdom will begin to answer for us. When is the best age to actually do risk prediction? If you're going to get breast cancer at 35 and you self-identify yourself as a Black woman, that's the kind of conversation that I have in our communities, right? What about the same person who is biracial but self-identifies herself as a white woman because her mother is white and she's getting instruction from her mother? These are very complex societal questions, existential questions for all of us.
But if
And
we get
that's why
100,000 women in this study, there may be some things that we can really contribute because of that.
Right.
So-
and we can do that through everyone participating and then having us learn from every woman who participates. That's why wisdom is looking for women informed. And the more informed we are, the more we'll be able to move this to the future. So I'm thinking in 10 years' time, we will have learned a lot that will move us from categorizing Black, white, Asian, Latino, to more precision. And that precision will get us to precision prevention. Because after all, what we want to do is prevent cancer.
That's right. Well, let's hope it's 5 years for me. Alad, you wanted to say something.
Yeah, I think that there was a question about sort of particularly women of color in terms of how to assess risk. So right now, although we're struggling to learn a lot, we also, we do in the Wisdom Trial use a model called the Breast Cancer Surveillance Consortium model, which does include data from women of the largest racial ethnic minorities in the United States. So there's individual risk calculations for women, African-American, Black women, and Latina women, and Asian women. So the model does actually include the baseline risk of those populations, and then superimposes on that information about mammographic density and genetics as well. So although there's a lot more to learn, we are
We're already applying the best of knowledge, and it's tailored already. Yeah, exactly. So I'm going to quickly answer a little bit of the second question, because unfortunately our time is almost at an end. This is such a fun panel. We could probably talk for like 2 more hours, and maybe we'll do it again. But I think the second question is, why did we pick 40 to 74? And why can't we include someone who's 30 and someone who had DCIS? And I particularly think that for many women, DCIS, for the vast majority of women, DCIS is really a risk factor, not so much a cancer. So why not? And in the future, we really do hope that we can take this information and create something that's more what we call wisdom for cancer. So we can apply all this knowledge about once people have been diagnosed, how do we think about screening and surveillance? And there's a lot of this work going on. And if you stay for the intern presentations, especially next week, we're going to talk a lot about all the work that's going on and trying to understand risk for DCIS and how to change the way we treat it. Highlight. So don't forget next week.
Can I push in one question?
Yeah, wait, let me just finish. But the other reason we're not doing 30 is that we don't screen currently women who are in their 30s. It is, if you have a family history and you should go and you have especially a strong family history, 10 years before the earliest onset of someone in your family, make sure you go in and talk to your either your primary physician or someone who can refer you to a high risk program. And again, the results will apply, and we would probably be thinking about a risk assessment at the age of 30, but we have to get our results first. And then I'm going to follow with a closing question. If there's, yes, Laura, because we only have 5 minutes left, so I'm going to ask a question of everyone to answer. Is there something else that we should be considering?
The question is, do I have to get my genes tested? And if I end up being high risk, what then? What next? What happens?
So it's a good question. So we ask women to be randomized, to be assigned by chance. If they come in, it's the best way to learn. But if you really feel strongly and you want to choose either annual screening or you want to choose the personalized arm, you can choose. If you are in the personalized arm and you just can't get yourself to send in the genetic test at the beginning, then that's okay too. We'll, however you start in, we're doing our best to try and make the arms even, but if you're struggling with it, give us a call and we'll talk about it. And if you are at high risk, we have breast health counselors and who will, and specialists who will talk to you and counsel you, and we have a whole prevention program. So there's extra resources for you, especially if you're at high risk. And even if you don't meet our highest criteria where we go out and find you, you can call us at any time, at any site around the country. So I want to close by asking each one of you a short answer. Really, it's COVID. It's the time of COVID. People are, obsessed with the pandemic as well. It's impacted everything in our lives. Does this matter? Does screening still matter? Should we still be pushing on answering these questions, and why? Short answer from each one of you. We'll start with you, Fumi. Oops, you're on mute. Fumi,
Say it's all about testing. We should prioritize joining wisdom. Cancer is worse than COVID, and if you are high risk, by getting tested, you will know about it. So I don't want women to get focused on COVID and not going for their screening. Very important.
It is. As long as you go to a facility that's safe and the rates in your particular state are low, it is 10 to 100 times less risky to get your screening. So Alad.
Yeah, I strongly agree. I would put my primary care physician hat on here and say that unfortunately, we've seen a lot of people put off care, not just breast cancer prevention, lots of other prevention and lots of other diagnostic testing that needs to be done for men and women, that people are just justifiably afraid of COVID, but not getting stuff done. And we've seen some negative health consequences of that. So, I would recommend wear your mask and get your breast cancer screening done. And if you're interested and willing, join the Wisdom Study.
Celia.
Oh, I'm going to put my patient hat, and I have resumed all my healthcare. When I go to UCSF, they take care of you. The distance is there. Everybody's wearing your mask. So I strongly recommend people to go back to their care. It's a safe environment.
Right. Kim?
So I'm on the ground testing in the community around COVID. And I think that I will go back to what I said about from Arnold Perkins. You can't lead where you won't go. So the thing is, what we're trying to do is incorporate information about breast cancer screening and wisdom along with COVID testing, because people are already there. And so there's an opportunity to actually capture the attention of folks. So absolutely, people should continue to screen, but I think as institutionalists, we have to find a way to reach the people with those messages while their mind is preoccupied with COVID.
And Jen.
Yeah, piggybacking off that, I think COVID is sort of an interesting example. I think many of us felt like COVID completely disrupted our lives and our ability to focus on our health But I think for many people, there sort of always already been those things. If you had housing insecurity, if you had food insecurity, depending on the number of jobs you're, all the family circumstances, incarceration interrupted people's ability to focus on their health. So what I'm really hoping is that we as researchers and as clinicians can figure out ways to take the tools we're using during COVID to reach people during this difficult time and apply them to reach people who already were having trouble accessing healthcare because of these outside factors.
Yeah. So, and I just close by saying, if you are tell everyone you know, it's very simple, wisdomstudy.org. Very simple. I'm sure everybody knows somebody, who could participate. Tell your friends and family, everybody of every race, color, walk of life. That's what we're hoping for, because now more than ever, you can see how important it is to know what your risk is. It's too bad we don't have the information, because people at lower risk wouldn't be worrying about it during the time of COVID, and people at higher risk would know absolutely they have to prioritize it in times and the time of COVID. So I want to thank everyone on the panel. This is such a fascinating discussion, and everyone had so much to contribute. I hope all of you out there learned as much as I did today, and we'll definitely do this again. We have another panel again next week, which is talking about rethinking the standard and how new classifiers of tumors can improve treatment. And one of the exciting things, the exciting opportunities we have, is to take everything we've learned from wisdom, find out how to understand who gets what kind of cancer. That's our huge opportunity. So now we have another treat for you. So stay tuned. We've got lots of great topics for the rest of our hour. We're going to start by having some lightning talks by our interns in the program, and they are our study coordinators. There are bright, ambitious young people who are the future of medicine, who are taking a year or two off from college, after college, before they apply to graduate school or medical school, and they are working with us and helping us advance our programs. And you're going to hear from them. And then we're going to have our Zumba class to get everyone stretching. Remember, part of healthy living is thinking about improving your mind, increasing your understanding, because knowledge is power, exercising your body. Next week, we're going to have, instead of our Zumba class, we're going to have a healthy cooking class. Also thinking about how we use our resources and don't have food waste. And then today, our big treat is going to be from Dr. Vanfier, learning about a new emerging test. It's not quite here yet, but it's called Circulating DNA, and how we think that can be used in the future to help us understand better. So stay tuned. Okay, so our next, so we have 6 very quick talks for you, and we are, or 7 really, we are going to talk quickly about personalizing treatment through research and care, right? So personalized intervention means if you have more risk, that we would escalate therapy, or if your response to therapy is better or is poor, we would escalate therapy. And if your risk is low and your response is higher, then we de-escalate to reduce morbidity. So that's really our kind of overarching theme for the day. So without further ado, we are going to start with our first talk, and I'm going to ask each of the interns who start to introduce themselves. And our first is Annie Patterson.
Great, thanks, Dr. Esserman. Hi, everyone. I'm Annie, and I am presenting today on the use of antibiotics in implant-based reconstruction following mastectomy. Next slide. Many breast reconstructions following mastectomies are performed in the US each year. Within the American Society of Plastic Surgeons, more than 107,000 occurred in 2019. Tissue expanders and implants were used in over 2/3 of these cases. We know that implants have a high infection rate. Surgical site infections have been reported to occur in anywhere between 10 to 35% of cases, which is much higher than the infection rates of clean surgeries and those of mastectomies alone. Infections are known to lead to poorer outcomes. It causes about 5% of people to temporarily lose their implants, and somewhere between 2 to 3 times that for people who also had radiation. It causes a higher cost of treatment and the delay of adjuvant therapies. Preoperative antibiotics have already been shown to decrease surgical site infections and are standard of care. However, there's controversy in the use of antibiotics for prevention of infection postoperatively. Next slide. Due to this lack of consensus, doctors are questioning how they can best prevent infections. There's a few ideas on how this can be done. One strategy would be to use antibiotics in the first 24 hours after surgery. Proponents of this argue that there's been evidence that the risk of antibiotics outweighs the benefit. They say that antibiotics, when used prophylactically, has corresponded with later and higher grade infections due to the selection for antibiotic-resistant organisms, causing poorer surgical outcomes. Second, some have proposed using antibiotics plus the alteration of the bacterial microbiome. There's may be a role for probiotics in treating these infections, and altering the microbiome may reduce complications for patients without creating other risk factors. Third, some propose sticking to the status quo and that prolonged antibiotics are best. So this would mean prescribing antibiotics for a longer course. So sometimes this is a particular number of days or another marker of time, like when drains are removed. Next slide. When there's uncertainty in best clinical practice, solutions come from randomized controlled trials to help challenge current beliefs and to try to help the medical field do better. A lot of doctors are still relying on anecdotal experiences and current habits in prescribing antibiotics postoperatively, and this is not helping to reduce infection rates. Randomized controlled trials have a high quality of evidence, higher towards the top of the levels of evidence pyramid shown on this slide. They are the best evidence available because researchers can work to control as many factors as possible to learn about the research problem they're investigating. There's currently several trials being conducted investigating the use of antibiotics postoperatively, and we hope these will be instrumental in answering questions about the effectiveness of interventions to help improve clinical care for patients receiving implant-based reconstructions following mastectomy. Thank you.
So great. Thank you so much, Annie. And as you heard on the panel this morning, we, as you heard on the panel this morning, we learned a lot about the wisdom study, which is how we're trying to understand risk so we can assign the best screening practice. Now you're going to hear Hallie Thanakal tell us about how to apply those same ideas for people with cancer and how we're starting to think about that. Holly.
Hi, everyone. Thanks, Dr. Esserman. I'm going to be talking about wisdom for cancer and the idea of using personal risk to inform surgical decisions for breast cancer patients. Next slide. First, what is wisdom for cancer? Wisdom for cancer is the idea of learning more information about patients so we can both personalize their care and improve treatment. And there are two parts to this. The first is on the left-hand side. It's the idea of examining the patient's DNA to see whether or not they might have an inherited risk that puts them at an increased risk of developing a breast cancer. Genetic testing is how we can look at this, and this may influence surgical decisions, which we'll take a look at in just a minute. The other part is studying tumor biology on the right-hand side. We can look at the tumor's biology through a test called genomic profiling, which allows us to see if there are certain gene associations or biomarkers that may affect a response to therapy or risk of recurrence. And this may affect radiation or adjuvant treatment decisions, for example. So both of these pieces can be used to personalize care and follow up. So how patients are surveilled and how often they're coming back to clinic. Next slide. So how could this information actually affect a surgical decision? Well, in one case, a patient may have genetic testing and it's seen that they have a high-risk gene mutation. Well, in this case, they may consider, along with information about their age, their tumor size, and more, they may consider getting a prophylactic mastectomy in the breast that they didn't develop a breast cancer as a preventative measure. Click once, please. In another case, if a patient has genetic testing and it's seen that there's no high-risk genetic mutation and they have a low polygenic risk score, which is another influencer of risk found in the DNA, this may support the decision to conserve more breast tissue. So big picture here, the idea is to tailor the surgical decision to each patient's individual risk, which would reduce overtreatment and undertreatment. And in the future, if we can aggregate all of this information, If we can use it to sharpen predictive risk models, which would improve breast cancer treatment, screening, and surveillance after cancer. Next slide. So how can you join? Well, Wisdom for Cancer hasn't yet launched, but plans to by the end of 2020. And if you want to help us study genetic factors, you can join a genetic testing station, which we hope to make available to all UCSF breast cancer patients. And if you want to help us study the tumor's genome, you can join a tumor genome registry called the FLEX registry, which is already live at many institutions across the nation. And we hope that you will join. Any UCSF breast cancer patient with a first diagnosis of breast cancer can join stage 1 through 3, and you will undergo a tumor genome test. When seeking care at UCSF, your clinician will refer you to study coordinators. Thank you.
So thanks for telling us about that. We're excited. This is just another way that we will start a pilot program that we hope we can then launch into a much larger program in the future. So our next presenter, Annika Kristofferson, is going to tell us a little bit about what the challenges are of treating metastatic cancer and why that's a harder cancer to treat than early stage cancer. Annika.
Thanks, Dr. Esserman. Hi, everyone. My name is Annika. I am one of the I-SPY 2 trial clinical coordinators. As you will learn more about today, I-SPY 2 is an adaptive clinical trial for locally advanced breast cancer, and it is designed to increase the efficiency of getting our novel agents to patients sooner. However, today I will be discussing the challenges of treating metastatic disease. What makes metastatic disease different? Metastatic disease is when cancer has spread to distant organs. Early stage breast cancer, as seen in the blue box, is treated with curative intent. Stage 4, or metastatic breast cancer, as seen in the green, is a chronic condition. Cancer can metastasize in 2 different ways. One of those is through the bloodstream, and the other is through the lymph nodes. Metastatic disease is complex. Once the cancer has spread to the new organs, it can spread to multiple different organs, and those environments are all very different. Once those cells are in those different organs, they then adapt to those different environments, making it a much more complex target. Next slide, please. So why is metastatic disease more challenging to treat? One of those reasons is the complexity. As seen in the red, it is much easier to suppress these adapting cells to these new organ environments than to kill them. The second reason is that surgical removal is challenging. It is not the primary treatment for metastatic disease. The third reason is that cells can learn to escape from the environment and the treatment that they're receiving. So if you have already received a therapy already, your cells then adapt to that and hide from it. This can lead to drug resistance. Next slide, please. Because metastatic disease is challenging to treat, one of our main goals is to prevent metastatic disease. The purpose of this slide is to show the vast range of therapeutic targets that we have developed to prevent metastatic disease. On the left, we can see the areas of the hallmarks of cancer that we have already targeted. And on the right, the associated specific drugs that we have already used. Our main goal is to target all of the hallmarks of cancer and bring these treatments to patients sooner. As you will learn more about in later presentations today, we can utilize the efficient and patient-centric clinical trial design as seen in the I-SPY 2 trial to bring these most effective novel therapies to patients sooner. Thank you.
Thanks so much, Annika. And building on that, you're going to learn a little bit more about why we want to move drug development to the early stage setting as well as the metastatic setting, and how we can find an earlier endpoint to know when we have been successful. So Sonal Shad is going to take us through that idea.
Thank you, Dr. Esserman. My name is Sonal, and I will be speaking to you about 2 aspects of drug development, particularly moving drug development to the setting of early stage cancers and using early endpoints to accelerate the drug approval process. Next slide, please. As you might know, before a drug is approved by the FDA for use in patients, it is first tested in animal models in what's called the preclinical research stage, shown in green, followed by clinical research in which it's tested in humans in 3 distinct phases. Typically, cancer drugs are first tested in and approved for metastatic patients. These patients have already been through multiple lines of therapy, including chemotherapy, radiation, and are very vulnerable to highly toxic side effects. As Annika mentioned earlier, advanced cancers also have a high risk of developing drug resistance, which can lead to low efficacy of these drugs. This combination of high toxicity and low efficacy leads to a high failure rate for these drugs. In addition, it can take a long time for these drugs to be approved for use in early stage cancer patients. The goal here is to test drugs in the early stage cancers, independent of their testing in metastatic settings. And here's why. Early stage cancers are more likely to respond to treatment, and so we can have greater impacts of treatment in early stage cancers. We can directly observe the impact and any associated toxicity of these treatments in early stage patients. And finally, we can test these drugs for their ability to cure cancer instead of just their ability to prolong survival. Next slide, please. In order for a drug to be approved by the FDA, it needs to answer a few questions. Are the patients living longer? Are they living better? These questions are answered using long-term follow-ups, in which data is collected over 5, 10 years, or even longer. You might ask the question, are there biomarkers in the short term, markers that can be assessed right after treatment that can predict what the long-term follow-up will tell us? And the answer is yes. In breast cancer, the complete absence of tumor after neoadjuvant therapy, called PCR, is one such marker. It can predict long-term survival in patients and can be used as an early endpoint to get conditional approval for promising drugs, while we wait for actual follow-up data to be collected. Next slide, please. The I-SPY trial uses both these strategies, testing drugs in the early stage setting and using PCR as an early endpoint in order to accelerate the drug approval process. To give you an example, Herceptin is a drug that entered its first clinical trial in 1993 in metastatic patients and was finally approved for early stage cancers by 2008. On the other hand, pembrolizumab entered a metastatic clinical cancer trial in 2013 and was almost simultaneously tested in early stage cancer patients in I-SPY in 2015. To date, we've collected enough data for the FDA to make a decision on the use of pembrolizumab early next year. And this has shortened, these strategies have shortened the pipeline to almost half the time it took Herceptin. Thank you.
So thank you so much, Sonal. And that's really that's so exciting. And we want to continue to cut that time in half. And now you're going to see how we can use those early endpoints to maybe further reduce or tailor the time of treatment. And Eben, one of our I-SPY coordinators, is going to talk to us about that.
Yes, hi everyone, my name is Eben, and today I will be discussing how we can use imaging and pathology to decrease the duration of chemotherapy. Next slide, please. So currently at UCSF, we see a model where basically this one trial, the I-SPY trial, fits all patients. And with that, we see that there's really one direct route to surgery for all patients. So under this model, moving from left to right, we see that patients first undergo screening, they're randomized to a particular arm of the trial, at which point they receive the first drug regimen, which is Taxol, for 12 weekly cycles. After those 12 weeks, patients then have an MRI and a biopsy, which traditionally has just been used as a marker to monitor treatment and their progression. Afterwards, patients go on and receive the second drug regimen, AC, for 4 biweekly cycles, and then they move on to surgery where they're evaluated for whether or not there's cancer left. And so our goal and the vision and what we're proposing as a way to de-escalate and personalize medicine for each patient is to provide an alternative route for patients to bypass this second drug regimen, AC, for patients that are showing a good response. So what we want to do is utilize that 12-week time point, both the MRI and the biopsy, to analyze patients that really need to continue with chemotherapy versus the patients that can skip and proceed straight to surgery, as highlighted in that yellow arrow. Next slide, please. So what exactly would that look like? Here on this slide, we have images, MRI images of patients, patient number 1 and patient number 2, both before treatment and then at that 12-point time point that we were talking about. So if we look on the left, we see patient number 1, we can see their MRI slides before treatment. And then if we look at the bottom, we can see that at that 12-week time point, there is still tumor present, as highlighted by these in the yellow box. And that is also confirmed with the pathology slides in pink. Versus on the right, we see patient number 2, who we can see their tumor before treatment. And then we can see that at that 12-week time point, that there is no presence of invasive cancer, which is both confirmed from the MRI images as well as through the pathology slides. Next slide. And so here we can just see again a visual of just how these patients are progressing and the tumor volume calculated from their MRI images throughout treatment. And we can see that, you know, while both patients are in fact responding to treatment, we see that patient number 2 just has a more significant response. Next slide, please. So in conclusion, the purpose of all of this is to personalize care for all of our patients. We know that AC is really hard on patients, and so if patients don't need it, then they shouldn't have to get it. Additionally, personalizing care does not mean that cancer is fought any less aggressively. If at the time of surgery, it is still found that patients do still have cancer present, then they can receive that AC after surgery. And so all of this is to say that if patients are ready for surgery, we shouldn't have to put any more time, energy, or money into a treatment that's not necessary. Thank you.
Thank you, Eben. And then our next presentation by Soumya is going to talk about getting information from you about toxicity and why that matters. Soumya. Soumya, I think you're on mute. Go ahead.
Thank you, Dr. Esserman. My name is Soumya, and today I'm going to be talking about patient-reported outcomes and why they matter. Next. So patient-reported outcome is any report of the status of a patient's health that comes directly from the patient without its interpretation by a clinician or anyone else. Patient-reported outcomes can capture many different facets of treatment and disease, from physical, psychological, social, economic, as well as adverse reactions to treatment and symptoms of disease. One such example is this National Comprehensive Cancer Network's distress thermometer, which is a screening tool for measuring distress. And patient-reported outcomes can be captured through a variety of instruments, from paper surveys, online surveys, and smartphone apps. Next slide. So why are patient-reported outcomes important? Well, first, no one quite understands how a patient feels quite like a patient. Improving the capture of the impacts of disease and treatment on the patients can improve the quality of clinical care. And integrating patient-reported outcomes with clinical care can allow for earlier responsiveness to patient symptoms, better symptom management counseling, better dose modifications, and referrals to supportive care services. In fact, one such study, which looked at integrating patient-reported outcomes into the routine care of metastatic cancer patients, found that this was associated with increased survival compared to routine care alone. And as researchers, patient-reported outcomes are important because they allow us to incorporate the patient's experience of toxicities into the clinical assessment of new drugs to develop treatments that are not only more effective, but also less toxic. Next slide. So how are we using patient-reported outcomes at UCSF? One such example is with the Athena intake survey. Whenever a new patient appointment is scheduled at the breast care center, it automatically triggers this survey to be sent out to the patient. The survey, which captures many different aspects of patient-reported outcomes, generates a summary which is directly uploaded to the electronic medical record. This allows the clinician to better address those concerns in that first initial clinic visit. Also, even before you come in, based on inbuilt thresholds within the survey, it automatically places referrals to supportive care services like psycho-oncology, genetic counseling, nutrition, etc., so that you are getting the care that you need. And as researchers, this also really helps us understand the patient experience and how we can help. Next slide. Another example of how we're using patient-reported outcomes is within the I-SPY2 clinical trial, which Eben talked about before me, where we measure efficacy of novel therapeutic agents in the pre-surgery or neoadjuvant therapy and use the residual cancer burden at the time of surgery or pathological complete response or PCR to measure that efficacy. But we also administer patient-reported outcome surveys at baseline with treatment at surgery and follow-up to understand how these treatments are impacting your quality of life and the toxicities associated with these drugs. Combining these two together, we can develop a quality of life index or a QOLIS that allows us to screen for drugs that are not only more effective, but also less toxic. So in the end, patient-reported outcomes matter because they allow us to incorporate the patient's voice into their clinical care as well as research. Thank you.
Thank you so much. And you can see how we're just trying to drive the personalization of treatment, into research and care at UCSF. And our final presenter, Allison, is going to tell us about ways in which we can use telehealth to really continue to improve your experience, even in the time of COVID, or more especially in the time of COVID. So, Allison.
Thank you, Dr. Esserman. And it's great to speak to you all today. I hope you've enjoyed the presentation so far. My name is Allison, and today I will be presenting on telehealth and patient care in the time of COVID. Next slide, please. So first, I'd like to begin with a story as we begin to explore what unique challenges patients face during this pandemic. And just a few weeks ago, one of my fellow student interns was supporting an elderly breast cancer patient, who I'll call Pam, with question listing and note-taking services for her upcoming visit at UCSF. And one of the questions that arose for Pam was, how will I safely get to UCSF? Given the 45 public transportation wasn't much of an option for Pam, and luckily a close friend had offered to drive Pam, but this also led her to feel anxious about the risk for COVID transmission in a confined car. So ultimately, Pam decided that they would drive to the clinic with the windows down, with hopes that this would limit COVID infection risk. And so for many patients, and perhaps some of you today, what resonates in Pam's story is a shared feeling of greater vulnerability to COVID, as well as an anxiety about delaying your care. And given the quarantine and social distancing measures that we've all experienced, there's also a very real increase in social isolation, which simply highlights our need for social support. Next slide, please. So one way that UCSF can support patients during this time is through the help of student interns like myself at the Patient Support Corps, which for decades has helped patients develop questions, record consultations, and take notes during their visit. And now we've developed a way to do all of this virtually. So in Pam's case, prior to her visit, an intern first spoke to her to get a sense of her diagnosis and to offer informational materials. The intern then helped Pam develop questions and an organized question list for both the provider and Pam to run for her appointment. During the visit, this intern virtually attended via Zoom, took notes, and recorded the appointment for Pam. Afterwards, the intern sent along the notes and the recording so that Pam could make an informed decision, all without having to increase her risk for COVID. Next slide, please. So most importantly, throughout this pandemic, we've learned that it is safe to receive your care and participate in the clinical studies that were mentioned today. In fact, it's actually riskier to delay your cancer treatment. And through services like the Patient Support Corps, we've also learned that you do not have to face your treatments nor your treatment decisions alone. Having social support still remains an essential part of care, regardless of this pandemic. And luckily, video visits have made it even easier for loved ones and student interns to participate. You can also record and have your own trusted note taker during the visit. Ultimately, share your concerns with your providers so that they can continue providing safe care for you. Next slide, please. So throughout your time at UCSF, the Patient Support Corps is here to help you. So I warmly welcome you to visit our website for more resources, or please feel free to leave us a message to request our service. Thank you.
Thank you so much, Allison. And a big round of applause, virtual applause for all of our interns. You guys did such a fabulous job. And don't forget that next week, you're going to hear 7 more great talks and another fabulous panel about rethinking the way we classify our tumors to improve treatment. So next, I hope all of you are ready with your exercise clothes on. We have a real treat for you with Judy Young and Angie Shen, and they're going to give us a Zumba class. I hope everyone's ready to get moving this morning. And I'm going to turn it over to my inestimable, vigorous, enthusiastic colleague, Judy Young and Angie Shen.
Hello. It's so good to see all of you.
Hey, everyone.
Hi. We are so excited to be here and be a part of the Taste for Cure, and just want to thank Laura Esserman and Melinda Walker for inviting us to be a part of this wonderful day. So thank you. My name is Judy Young.
And I'm Angie Shen.
And we are Jam for Joy. This is Teru. This is Angie's mother, who is joining us today as well. And we are just so excited to be here. We are Jam for Joy, and we've been teaching together for 5 years. And we just wanted to be here today to share with you some movement. We also, just so you know, we are also, Jam for Joy is our part-time gig. We are also full-time employees at UCSF in the Department of Obstetrics, Gynecology, and Reproductive Sciences. And Teru is a retiree of UCSF. So we are UCSF proud here representing. So we want you to know that. So we are all UCSF folks. Our mission at Jam for Joy is really about building community, whether we're in person or whether we are virtual. We are really about building community through this screen or in person to really encourage healthy movement through Zumba. And it's so important. I know, as Dr. Esserman has been talking about moving, healthy movement, partly to release our stress, also just to process all the things that we've been going through this year and beyond. Everything that happens to us, healthy movement is a way to process our emotions. It's a way to release the stress, but it's also a way to release and express the gratitude and joy that we have, and to get in touch with our bodies. And so at whatever level you can move at, it's so important to just be able to move, and Zumba is a healthy way to do that. So that's what we are about, is encouraging people to find that way to get in touch with their bodies and to express that movement, whether it's joy, sadness, releasing stress, releasing anger, whatever it is, we're doing it through movement. We offer free daily classes, and you can check in the chat. We're going to put in the chat our email, which is jamforjoy2020@gmail. If you'd like to get more information about joining our daily classes, we'll put that in the chat as well. And you're welcome to join our free classes at any time. As we get ready to move, I just want to offer you some safety precautions. Take a look around your space. Make sure that if you have any shoes or anything that are in the way, you should have shoes on to move. But if you have anything that will trip you up, that furniture is pushed a little bit out of the way so that you have a safe environment and clear space to move. We want to make sure that you're not going to fall. That's really important. We also want to say that it's really important. We have 5 songs to share. It's really important to know that you can modify any of these songs to your own ability level. Modification is really important in Zumba, and we're going to show you a couple of different things. The person in front is going to be leading at full movement for the songs. The person that's further back, one of us will be a little further back, and we're going to show you some modifications. And Teru is going to be sitting down, and she's going to be doing the movements in a chair. And so you'll see a couple of different options, but Zumba is, you can do anything you want with Zumba. So if you don't like any of the movements we're doing, you're free to modify to whatever ability level you'd like, or whatever style you'd like as well. So most importantly, have fun, try the moves out, and enjoy yourself. Anything you want to add, Angie?
No, just to have fun, and remember, it's not about the moves. It's just about expressing your joy and enjoying the energy that comes through the screen. So yeah, just have fun with it.
That's it.
All right, we're going to get started. Make sure that you take as many breaks as you need to and drink water along the way and stay hydrated. Here we go.
Tú Desse jeitinho. Oi. É Jerry Smith, papai. Nesse jogo eu não vou tá sozinho. Eu vou chamar todos os contatinhos pra assistir da minha camarote. Vários bumbum que é pra me dar mais sorte. Só que o combinado é o seguinte: 90 minutos sem perder o pique. Bola na trave, dá uma tremidinha. É escanteio, dá uma empinadinha. Volta, volta. Volta, volta, rebola pra baixo, volta, rebola pra cima, faz um movimento novo, quica, quica, quicadinha. Volta, rebola pra baixo, volta, rebola pra cima, faz um movimento novo, quica, quica, quicadinha. Vamos fazer o bumbum delas que caem igual bola. Vem! Quica, 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 quica. Quica, 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 quica. É Jerry Smith, papai. Nesse jogo eu não vou tá sozinho. Eu vou chamar todos os contatinhos pra assistir da minha camarote. Vários bumbum que é pra me dar mais sorte. Só que o combinado é o seguinte: 90 minutos sem perder o pique. Bola na trave, dá uma tremidinha. É escanteio, dá uma empinadinha. Volta, volta. Volta, volta, rebola pra baixo, volta, rebola pra cima, faz um movimento novo, quica, quica, quicadinha. Volta, rebola pra baixo, volta, rebola pra cima, faz um movimento novo, quica, quica, quicadinha. Vamos fazer o bumbum delas que caem igual bola. Vem! Quica, 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 quica. Quica, 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 quica. É Jerry Smith, papai.
Muñequita linda de los algodones. No te vayas ahora, mami, que esto se compone ti, muchachita de mi amor. Traiga la medicina para el dolor. Con tus besos y tu calor, curas la maldición de mi mal de amor. Ojo que no ven, corazón que no siente. Te fuiste dejando una marca a mi mente. Amor con amor se cura. Mujer como tú no la vi más dura. Y ay, qué locura. Llegó otro caballo de tu estatura. Esa sabrosura. Pa' bajarme la calentura.
I hope this shit don't stop. Come and let me get on top. Brought you a big old rock. All this drug need a big old mop. Look, how many licks till I get to your spot? Girl, can I lick you a lot? I like Patron, straight on the rocks. And just like Patron, my wrist on the rocks.
Muñequita linda de los algodones. No te vayas ahora, mami. Esto se compone. Hice un juramento y no lo cumplí. Por mujer no lloro y lloré por ti, muchachita de mi amor. Traiga la medicina para el dolor. Con tus besos y tu calor, curas la maldición de mi mal de amor.
Call me baby, girl, you got me going crazy. I ain't never felt this way. I've been looking for my baby. Oh, call me crazy. I pull up to all your places. I got your heart, ain't mean to break it. I got your heart, ain't mean to break it.
Vívela como quieras, gózala a tu manera. Que todo siga como tiene que seguir, que la vida es una aventura, así que ríe cuando tengas que reír. Vívela como quieras, que todo llega cuando tiene que llegar. Gózala a tu manera, que todo pasa cuando tiene que pasar. Que todo siga como tiene que seguir, que la vida es una aventura, así que ríe cuando I'm not the baddest trick you like. It ain't my fault that I'm out here getting loose. Gotta blame it on the goose. Gotta blame it on my juice, baby. It ain't my fault that I'm out here making news. I'm the put it in the proof. Gotta blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. No, I'm not a snack at all. Look, baby, I'm a whole meal. David, you ain't being slick. Don't dare try to cop a feel. The juice ain't worth the squeeze if the juice don't look like this. Hold up, baby, please don't make me have to take your shower. If I'm shining, everybody gonna shine. I was born like this, don't even gotta try. I like shot a nigga better over time. Heard you say I'm not the baddest trick you like. It ain't my fault that I'm out here getting loose. Gotta blame it on the goose. Gotta blame it on my juice, baby. It ain't my fault that I'm out here making news. I'm the put it in the proof. Gotta blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Hey, somebody come get this man. I think he got lost in my DMs. What? My DMs. What? You better come get your man. I think he wanna be way more than friends. What? More than friends. What you want me to say? It ain't my fault that I'm out here getting loose. Gotta blame it on the goose. Gotta blame it on my juice, baby. It ain't my fault that I'm out here making news. I'm the put it in the proof. Gotta blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Yeah.
Judy and Angie, that was fabulous. Thank you so much. Oh, Judy, I want the outfit though. I want the fringe on the exercise pants. I think everyone needs, and I want the shoes too. All right, so I think everyone, no matter what your style is, this is the importance of getting up and moving, right?
Yes.
Especially in COVID. Every day, I'm on Zoom calls from 6 a.m. sometimes till 10 at night. I want a chance to get up and move. This is just so inspiring. Let us know when your classes are, and maybe we'll have a special breast cancer survivors Zumba class every week, and I'm going to join.
Wonderful.
Judy and Angie, thanks for getting us up and moving and inspiring us.
Thank you, Dr. Esterman.
Thanks for having us. We look forward to seeing you all again soon.
I need it. I want the pants. Okay.
All right, we'll work it out.
Okay, so we're moving right along to our next exciting presentation, and we're going to catch up. We're not going to keep you maybe a couple minutes after 11, but I really am so excited to invite my dear friend and colleague, Laura Vantveer, who is one of the most outstanding molecular biologists in the world, has dedicated her life to personalizing the approach to breast cancer treatment through better understanding of the genetics or the makeup of your tumor. And now she's going to tell us about an exciting development that is, in evolution, and how we can find little footprints and fingerprints of that tumor DNA in the blood, and how that might actually help us change the way we treat and screen for breast cancer. Laura.
Yes, thank you very much for the introduction. It's hard to follow this very active Zumba class. I was participating myself, super. But I will give you 5 minutes more of some brain exercise so that you keep thinking about what's next in breast cancer and where are we going. So I'll be talking about circulating tumor DNA, and I'm at UCSF a professor in laboratory medicine. So what are we actually trying to do here? So breast cancer is, of course, something that affects the whole trajectory from when somebody is healthy Do I have a cancer risk? I should be screened. Then there's the diagnosis. What is my cancer type? What is my response to the therapy? And then what is my outcome? Do I have a recurrence risk or not? And so throughout, one wants to know, and physicians are monitoring early signs of disease, response to treatment, and recurrence. As many of you will have experienced, that of course starts with mammograms at age 40, as we were just discussing, or personalized. Sometimes an MRI is involved, and a diagnosis again often either comes by somebody feels a lump in the breast or is detected by one of these screening modalities. And then while somebody is being treated, the response often in the breast is monitored again by imaging. And after all of that is done in survivorship, imaging plays a role again. But how about if much of that we could replace by just a simple blood tube, and that we would identify in the blood tube what is going on in the body? I'm going to tell you, we're not there completely, but we're studying and we're making progress. So what is circulating tumor DNA? Scientists have discovered that dying tumor cells release small pieces of their DNA into the bloodstream. And dying tumor cells is something that happens all the time as a tumor is growing. So that's a feature of having a tumor. And these pieces are called cell-free circulating tumor DNA. You can see them here in the bloodstream. So the question is, can we isolate the specific circulating tumor DNA from blood for early detection, therapy response, and early signs of recurrence? It seems that this circulating tumor DNA is more sensitive, and some of you in the past may have heard about circulating tumor cells. That's still also part of studies. Tumor cells are a little bit less sensitive, it seems. The big new thing is that ctDNA is more specific and more easily to be detected. So what do we look for in the blood? So if you take a normal, a healthy person and a cancer patient, then a healthy person also has circulating DNA, but that's all normal DNA. Whereas for a cancer patient, that is mixed with tumor cell-free DNA. And what we want to do is to detect those specific DNA mutations that come from the DNA from the tumor. So a cancer patient has both in circulation, still normal DNA, but then also the specific tumor DNA. So when should we be looking? So here, maybe first of all, on the top, you have a clinical diagnosis. Some patients have neoadjuvant therapy, surgery. Some patients have chemotherapy after surgery, hormonal treatment, and there might be a clinical recurrence. So what we are using and studying for this ctDNA is early detection, monitoring for tailoring treatment, minimal residual disease detection, monitoring for response, and assessing resistance. And you can see here that there's this trajectory of ctDNA given that if it comes above this dotted line, you can detect it in the blood. Whereas in comparison, detection by imaging, much more tumor needs to be present before that's seen. So I'll give you one example of what we're doing. We're interested actually studying this in all of these aspects, early detection, as well as survivorship, but I will show you one study we're doing currently in the I-SPY trial where patients are being treated for breast cancer. So what happens? So the tumor has specific changes in the DNA, so-called mutations. And what we do, first of all, we identify those changes and we identify 16 that are the best suitable for this ctDNA blood testing. So here they are depicted as 16 different ones from the DNA. We then isolate ctDNA from a blood sample and we sequence the blood to see whether those mutations from the tumor are actually present in the blood. And in this case here, you can see there is one present in the blood, where actually 2 is a minimum to call blood positive. And so we assess how many of those are present in the blood. And here we are monitoring the ctDNA status during treatment at different time points. So T0 is when somebody is diagnosed. Then in the I-SPY trial where we're studying this, patients get a certain treatment. You can see here the drugs. in green and in pink. And so we have other blood draws, and what we want to see, does the ctDNA in the blood go down, as in this example, which means a response to the treatment? And how is the treatment at time of surgery T3? So in this particular example, this is one patient that is positive at the start. The patient response to treatment stays more or less the same, goes further down, and then is negative for ctDNA at surgery, which is what one would hope for. So the question is, how does it actually, what does it bring us as a predictor? So Mark McBanois, one of the scientists here at UCSF, with a whole group of people, and we do this in collaboration with the company Natera. So here's the I-SPY schema. So where patients are being diagnosed, there are 2 different treatment steps, and blood draws are here done at different time points and then followed by surgery. So we've done now for a few hundred patients, and we're still building our knowledge here with more. So what is the mutation of a given patient at T0 on their biopsy? When we isolate the circulating tumor cells in the blood, what is the status of those 16? And what we see here across a series of patients, some are actually negative almost all the time. Some start positive, clear really quickly at T1. For others, it takes a little longer. And a few patients are actually stay positive even at surgery. So one of the observations we have made is that if you clear early, that is very predictive that your treatment will result in a complete remission of your tumor, called PCR. And if you, the other observation is, if you're one of those people, which is fortunately only few, but those we want to identify, if you have still circulating tumor DNA at time of surgery, T3, then your recurrence, which is here shown on a timeline, your probability of a recurrence is very high, because every step down here means that patient got a recurrence. Whereas if you are here on the top, there's the green, hardly anybody has a recurrence, and here only a few. So this gives us very important information. First of all, who has an early response? Maybe that's enough. Who has still ctDNA at time of surgery, and what should we do next? So my last slide in conclusion, so how does it look like in the future? And this is breast cancer, this is also studied in other cancer types. And this is my order of likelihood of success for implementation, which is one of the main drivers why I'm doing all this. So we can monitor the response. We're making that assessment in I-SPY right now, potential to change if something doesn't work to another therapy. We can monitor residual disease after the neoadjuvant therapy for decisions on additional treatment needed or not. One can monitor early signs of recurrence in follow-up. So maybe one step would be that then imaging should be done earlier than normally would be done after a year or 2 years, but as soon as one sees something in the blood, we have to study how to use all this. And of course, ultimately, we want to monitor early detection in healthy women, but we don't know yet what are the right markers. All the other ones can make use of the mutations in the tumor once it is diagnosed, but healthy women don't have a tumor yet, luckily, and so we don't really know what markers to look for. So as a reminder and a disclaimer, all of this is still in research, but as Dr. Esserman and I, the one thing we want to do is implement this all for patients so that we actually can make better decisions. So that was the end of my talk, and I think this will be the future. Somebody will go to the pharmacy and say, here are my genes, what do I need to do? Thank you very much.
Yeah, Laura, that's great. And keep your video on for just a second. I think it's really important, that we ask one question. And I think a lot of people say, oh, this is here. Why can't I just go out and get this test today? And I'd like you just to reflect on for a minute, that some of the shedding of this DNA, the body may take care of some of these. And I think one of the, before we use it in early detection, what are some of the things we really have to think for? And what are the harms that could be done if we introduce it too early or in the wrong way?
I think if we're talking about this early detection in healthy women, we also really need to make sure that what we are detecting are circulating tumor DNA fragments that relate to a tumor that will be very aggressive. So of course, breast cancer comes from on a whole spectrum, from very slow growing, benign, non-consequential cancers to high risk, very aggressive, fast growing cancers. And it's particularly important that these tests for early detection are specific to detect those fast growing, aggressive cancer, because those are the patients that we also early on would like to include in prevention studies. So this sentence here, we need to find the right markers. That is the important one, because if you would test for just like anything, you may do more harm because you would go after the people that actually whatever is growing is something that would never manifest itself, or
cause a problem.
That would be my caution there.
Yeah, great. Well, thank you so much. And that is, thank you so much. You, as always, take a really complicated subject and make it so incredibly clear. We're so lucky to have you. And I want to thank everyone for taking the time. You know, these circulating markers are being used in other cancers as well. And in fact, it's being used, you know, mostly for people who have advanced disease and lung and cancer in particular, but it is not ready for the early detection, but we are hoping sometime by mid to late next year, we'll be able to incorporate this into trials like the I-SPY trial or other ways in which we can advance the field. And, you know, I think Laura Vanfier really clearly showed the right order for implementation. So we make sure that we get to do the most good for the most people and minimize the harm. And as we said before, research really is the bedrock of how we make care better. We should be learning as we go on every single patient, and that should be the standard. But we have to be thoughtful about how we implement it, again, as Laura said, so we do the most good for the most people. I hope you've enjoyed today's Taste for the Cure. I hope it gives you a taste of science, a taste of how to get up and move every day, especially in the time of COVID, when you're glued to Zoom or stuck in your house. Make sure that you wear a mask and follow social guidelines for social distancing for COVID, but don't neglect your care, your treatment, prevention and screening. If you follow the guidelines, it's safe to do so. And please join us for day 2 on October 17th from 9 to 11. You can download the resource handout online. It's right here. And if you've signed up or registered, we'll make sure to send you this. We're going to have a recording of the event, and the slides from today, we'll have it posted online. We also want to let you know that we have extended our program to Berkeley. So those of you who live in the East Bay, there's now a satellite site, or we have our program can be accessed at the Berkeley side, and we are actually starting our screening program there, all part of the same UCSF family. So we're excited about that. We'll have that on the website, and be sure to come next week. The highlights for next week are, of course, our cooking demonstration. The inimitable Allie Mountford from Ends and Stems will teach us how to make sure we make use of everything that's in the refrigerator so we don't throw things out, we don't contribute to food waste, and we make delicious, healthy food. And you'll have another lightning round of fantastic talks from our interns and research coordinators, just like we had today. We're going to focus a little bit more on early detection and DCIS, and about how to personalize and find better therapies in that setting. And then finally, our panel is going to be about rethinking the standard, which is, of course, what we're always doing, rethinking the standard, how new classifications of tumors can really improve our treatment. So again, thanks to everyone, all the panelists, all the interns, all Melinda Walker and Samia, who really made this fantastic program possible. We'll actually have everything online for you, and we'll look forward to seeing all of you next Saturday at 9 a.m. sharp. And don't forget to move.